this last session is as important for the nursing student, and I would like to thank you, the nursing students who came. Really appreciate you coming here, because it's really important for you to see how we see, or other colleagues see, the importance of the nursing. So it is really important for you to see and look forward to a great and brighter future where you are the partners in the healthcare, and especially the family medicine department. So please have a seat. We are going to start now. Have a seat, please. Can I have your attention? So this nursing session has a very important guest from America, Robin Rudolph. The moderator will introduce her, but I just wanted to thank you and acknowledge that she came all the way from United States because she wanted to promote the nursing in Pakistan. And she is a PhD. She is PhD in nursing, so she is Doctor of Nursing and have great ideas. Of course, you will listen from her, but I wanted to thank her. And I wanted to emphasize on this point that not only Dr. Robin Rudolph came all on her expense and took her time off from the family and from her work, and came all the way on her own expense, but all of the APPNA delegates, all of them, including myself and Dr. Naeed, came on our own expense. We did not take a single monetary benefit from anybody, not even lodging. Of course, we thank RMU for the meals and the delicious lunches and tea. But other than that, we did not have, and we didn't expect. It's all for the love of the country and of course for me also RMU. So with that, I will invite the moderator for our last and final session, which is strengthening nursing care, and especially we will talk in the perspective of family practice. So the moderator for this session is Dr. Bushra Dar, and I'll invite her to come to the stage, please. Dr. Bushra Dar is a family practitioner in Minneapolis, Minnesota, and she is very staunch advocate of not only family practice but nursing as well. So when I say not only family practice but nursing as well, actually I'm saying that the nursing is very integral and essential part of the family care and the primary care. So it's a team. So it's not like doctors and nurses, it's a team, and so Dr. Bushra Dar is the right person to moderate this because she advocates the team approach in the family care. So with that, I invite Dr. Bushra Dar. Is she here? Yes. So she will introduce the speaker and the panelists and invite them. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. So here we are for the last session. I hope everybody still has some energy left, but cheer up, it's the last session. So like you introduced to me, I'm Dr. Bushra Dar. I'm a family practice physician for decades. I'm part of the APPNA lifetime member for a long time, and this is exactly why I'm part of the APPNA, because we are so passionate about everything that we do here in Pakistan too. So, and I'm also a president of the Minnesota chapter of APPNA. I'm really happy to be here as a part of the member of APPNA Merit Delegate, for this is a very special conference regarding building primary care capacity, which surely is a critical need in Pakistan. I must say it's been an amazing 2 days meeting and listening to so many amazing people, speakers, experts, and ideas. On behalf of APPNA, I'm really grateful for all the effort that has been made to put this whole amazing event together. I especially want to mention and thank Vice Chancellor of the Rawalpindi Medical University, and of course all the students who worked really hard to host this historic event. The enthusiasm and the energy of all the students is amazing, mashallah. And it's really your event. It is all about improvement to do better for your future. You guys are awesome. So please give a round of applause to the entire team of the Rawalpindi Medical College who made this event possible. So as you all know, the main focus of this event has been building primary care capacity, which is truly a critical need in Pakistan. So when we talk about primary care providers, who really are the doorkeepers of any health system, and are the doorkeepers and are the first responder for anybody who needs access to health. So as a family physician, in fact, any specialty physician, we all know how dependent we are on our nursing support and MAs. We cannot function without them. So nurses really do play a significant role in patient care. So in this session, we are going to talk about strengthening nursing care. So we really want to focus what we can do to help improve and bring the positive change in nursing care in Pakistan. And so it's been really an important but neglected area in the Pakistan. So to start this session, I'm going to just kind of read a few rules, and I'm going to invite the chair and the panelists on the stage, and then we'll have some time for the speaker and some question and answer session followed by that. So first of all, I'm going to invite our chair, Dr. Rafat Jan Rukunuddin. Dr. Rafat Jan is a professor of Aga Khan University School of Nursing and Midwifery. She is a former president of Midwifery Association of Pakistan and Pakistan Nursing Council. She is currently a member of PM Health Task Force, completing undergraduate at Aga Khan and a graduate study from North America. She has been grown in a preventive care system. She's introduced community-based health insurance system. She has worked with the medical colleges for family nurse practitioners. So I would like to invite Dr. Rafat Jan. Now I would like to invite our panelists. So our first panelist is Professor Ziaul Hal. He's the Dean of Pro-Vice Chancellor, Khyber Medical University. Professor Ziaul is the Pro-Vice Chancellor and first and the youngest professor and Dean of Public Health and Family Medicine, Khyber Medical University. He earned his PhD in the field of public health from the University of Glasgow, UK, under Government of Pakistan HEC scholarship, and postdoc from the University of Keighley, UK. He's a principal investigator of the several large ongoing studies. He established a family medicine department and started a family medicine diploma at KMU. He has developed tools for implementing family medicine approach in Pakistan, including essential health services packages, catchment population, and referral system. Professor Zia is a technical member on the majority of health committees as a public health specialist and currently working as the core member of the Health Policy Advisor Committee of Minister of Health, KP, and Task Force on Health and Well-being. He is a strong advocate of implementing family practice approach at Pakistan and wrote several articles and book chapters on it. He is honored with several awards for his services in the field of public health, including HEC Best University Teacher Award, HEC Best Researcher Award, and Lifetime Achievement Award. So I would like to invite Professor Rai. The next panelist is Shaheen Ghani. She is a lecturer, Institute of Nursing Science, Khyber Medical University. She is a member of Prime Minister National Healthcare Task Force, President Pakistan Nursing Association, KPK. Shaheen Ghani is a lecturer of Khyber Medical University, first the ex-director of Nursing MTI Lady Reading Hospital, Peshawar, KP, member of Prime Minister Task Force, like I said. And she is also has earned her post-RN degree from the Aga Khan University under CIDA scholarship, MPH under WHP scholarship, MSN from KMU. She has established the first constitute nursing institute in Khyber Medical University. She's a pioneer of the state of the skill lab and nursing service education department in MTI LRH, Peshawar. She is the principal investigator of the several ongoing studies. She has prepared many training manuals for services staff MTI LRH. She is a member on the majority of the committee as a nurse specialist and currently working as the core member to the Prime Minister Task Force. She is honored with gold medal in professional development. Next panelist is Rehana Elahi. She is a nursing director at Shaukat Khanum Hospital. She's a member of Prime Minister National Healthcare Task Force. So she started her career with a government job in '84 when she joined Instructor Public Health Nursing School after completion in the diploma of the Lady Health Visitor. Since young age, she was very enthusiastic about developing a career. So she then joined general nursing course. After this course, she worked for 4 years in the same institute. And after that, she proceeded to post-RN BSc degree. Then she joined some government job, and after that she joined Shaukat Khanum Medical Center. She then initiated some specialized education in the nursing, I think in the Cancer Institute. All right. So now I would like to please pause for her. And now I would like to invite our speaker, Robin Sheikh from USA. So Dr. Robin Sheikh is a school nurse with significant experience in adolescent and young adult mental health. She is full-time nurse at the Lincoln Sunbury Regional High School, a small suburban town outside Boston, Massachusetts, where she provides case management, immunization, and disease surveillance, prevention, education, and direct clinic care to adolescents. Robin also serves as an active member of school-based committee to address substance abuse. She offers has a trainer program in it's called Stop the Bleeding program, and she provided certified CPR instructions. Robin also hosts clinical mentorship for nurse practitioners and registered nurses. In 2016, she served on a delegation of advancing nurses to the Massachusetts State House in support of changing prescribing authority for the nurse practitioners. Robin is a member of National School Nursing Association, Massachusetts School Nurse Organization, and an inductee of Sigma Theta Tau International Honor Society, Phi Theta Kappa. She earned her master's in nursing in the Nurse Leadership track in Birmingham State University, then earned her doctorate in nursing practice in population health from the Quinnipiac University. Her DNP project identified the low referral rates for mental health services among homeless young adults at a local urban community center. The project resulted in a nearly 50% increase in the homeless youth utilization of the mental health services for the community center.
Thank you all for having me here at Rawalpindi University. Also, I'd like to thank APPNA for bringing me here all the way from Boston. So why me? Why the white person from America? I've been part of the DESI communication for over 30 years. I have 3 beautiful children with a Pakistani man. And when my children were growing up, I would often sing to them, Jibe, Jibe, Jibe Pakistan. And I meant it. All right, so I became a school nurse, and I chose to become a school nurse intentionally, and I have no intention of leaving my job anytime soon, because I had a medical crisis with one of my children, and it was a school nurse who identified that crisis. So let's start off with giving a definition of nursing. Nursing encompasses autonomous and collaborative care of individuals of all ages, families, groups, and communities, sick or well, and in all settings. Nursing includes the promotion of health, prevention of illness, and care of ill, disabled and dying patients, advocacy, promotion of safe environments, research, precipitation in shaping health policy, and patients and health systems management, as well as in education, are key nursing roles. So nursing is the largest healthcare profession in America. There are over 3.8 million registered nurses, with 3 times more nurses as compared to physicians. 3 times more. Nurses work in acute care, community settings, including private practice, health maintenance organizations, public health agencies, primary care clinics, home health care, nursing homes, urgent care clinics, outpatient surgical centers, insurance, and managed care companies, schools, mental health agencies, hospice, the military, industry, nursing education, healthcare research, although they predominantly work in hospitals. That's a lot of places that nurses are at. So, according to the Nursing Association, a patient's best interests are served by the healthcare system in which many different types of qualified professionals are available, accessible, and working together. Further, the ANA asserts that though the nurse often works collaboratively, nursing does not assist medicine or other fields. Nursing is a distinct profession, and a collaborative model demonstrates that nurses operate independently and not auxiliary to medicine and other disciplines. Therefore, the nurse and the physician relationship depends on collaboration. So how do we do it? What's our special sauce? Nurses use the nursing process, and we practice to the full extent of our education, experience, and scope of practice. We use these standards to guide us, and these professional standards guarantee that as nurses, we are accountable for our clinical decisions and actions, and for maintaining competencies during our career. The standards are patient-centered to promote the best possible outcomes for our patients and to minimize exposure to risk and harm. Nursing standards encourage us to persist, enhance our knowledge base through experience, continue education, and the latest evidence-based guidelines. While the nursing process itself provides standardization of nursing profession, the nursing process is a guide which is client-centered through 5 steps. So first, we collect assessment data, both subjective and objective. We analyze that data, we organize that data, and then we formulate our nursing diagnosis. Then we create a plan, and then we establish our client's goals and desired outcomes with measurable based on evidence-based practice. We implement what we've identified as our treatment plan, and then we evaluate, was that plan good? Were the outcomes that we assessed ensured? Here are our nursing diagnoses, because we also diagnose. A nursing diagnosis is different than a medical diagnosis. We have over 244 nursing diagnoses that deal with the human response to actual or potential health problems and life processes. For example, a medical diagnosis of a stroke provides information about a patient's pathology. The complementary nursing diagnosis may be impaired verbal communication, risk for falls, interrupted family process, and powerlessness, which provides a more holistic understanding of the impact of the stroke on the particular patient and his family. These nursing diagnoses will direct nursing interventions to obtain patient-specific outcomes. The care plan for each individual patient is based on assessment data. The assessment data and the patient's preferences guide the nurse in prioritizing nursing diagnosis and interventions. The medical diagnosis is only one piece of the assessment data and therefore cannot be used in determining factors for selecting nursing diagnosis. To explain this phenomenon a little further, many patients with a hip fracture, for example, may suffer from acute pain, risk for falls, or self-care deficits. However, others may suffer from anxiety, sleeplessness, and ineffective coping. My focus as a nurse is on the patient's real-time needs. So here's a quick look at our student nursing care plans, and I've had the pleasure of working with some medical providers in Boston who always say to me, like, I don't understand, what is this ineffective gas exchange? Like, they don't necessarily understand our definition as nurses. And when we write our notes, we document our nursing diagnosis. We don't write down patient has asthma or patient has COPD. We write down what our nursing diagnoses are because we're nurses. So this patient is being seen for dyspnea, difficulty breathing. My diagnosis may be impaired gas exchange related to collection of mucus. Then I might have my interactions, which they can be independent actions, the things that I do as a nurse, or they may be dependent actions, things that I need to get a doctor's order for, or they may be part of a collaborative relationship, which require knowledge, skills, and expertise of another healthcare provider. So there are 4 ways to becoming a registered nurse in America. There's the diploma nurse, which is being phased out. The associate degree nurse, which is where I started 8 years ago. Then there's the bachelor's nurse, and then the accelerated second degree bachelor's program for students who possess a bachelorette degree in another field. Regardless of all the pathways, all registered nurses must pass the National Council Licensing Examination for Registered Nurses. It's called NCLEX, which is administered by the National Council of State Boards of Nursing, NCSBN, before they're granted a license to practice. And in 2011, the Institute of Medicine issued the Future of Nursing, Leading Change, Advanced Health Recommendations towards Nursing Roles, Responsibilities, and Education. And one of those recommendations was to have the BSN as the entrance for nursing. At this point in America, it's only at 50 to 60%. I don't believe that the ADN is going to be disappearing anytime soon. There are too many people in America that need nursing services, and the expectation that a BSN is going to be able to fill that need is too high of a level as an entry. Here are some of the other certifications that nurses can get once they have gotten their ADN. It's not a complete list, and I don't know if any of you can actually read any of those, but there are definitely expanded roles for the nurse. So registered nurses may advance their degree and practice nursing at the graduate level. They have an expert level of knowledge, complex decision-making skills, and clinical competencies for expanding practice specific to the context in which they are credentialed to work. Classes may be either in person, online, or hybrid, which is a mix of online and traditional instruction. And again, this is not a complete list of entry-level master's programs, but this is some of the master's programs. Nursing leadership, nursing education, and nursing informatics, forensic nursing, and clinical nurse specialists will not be prescribing medications. However, the nurse practitioner in all those other choices and fields, family health, psychiatric health, mental health, pediatrics, acute care, etc., can prescribe medications. After completing an advanced nursing degree program, they sit for a nationalized certified exam in their specialty to become a certified nurse practitioner. So here are some of the classes that a nurse practitioner may take. And you can see there's quite a few. And these are some of the things they'll be doing: taking and recording patients' medical histories and symptoms, perform physical examinations and observe their patients, create patient care plans and contribute to existing plans, perform and order diagnostic tests, operate and monitor medical equipment, diagnose various health problems, analyze tests and results, and change changes in the patient's condition and alter treatment plans as needed, prescribe patients medicines and treatments, evaluate a patient's response to medicines and treatments, consult with a doctor or other healthcare providers as needed, counsel and teach patients and their families how to stay healthy or manage their illnesses or injuries, conduct research, and the nurse practitioners never go beyond their scope of practice. Just as any other medical provider, we refer out. If we are unsure of what we're looking at, we're going to refer. The nurse midwife may be a primary maternity care provider to women, including gynecological exams, family planning services, and prenatal care. They deliver babies, manage emergency situations during labor, repair lacerations, and may provide surgical assistance to a physician during cesarean birth. So in America, there are over 270,000 nurse practitioners. Nurse practitioners are authorized to prescribe medications, as I said earlier, and this is very important, nurses prescribe medication under the exclusive licensure authority of the State Board of Nursing as recommended by the Institute of Medicine and the National Council of State Boards of Nursing. However, each state has their own policy on supervision requirements, which fall into two basic categories. One is full practice or collaborative practice, and in both cases, the nurse practitioner does not need a physician to provide oversight to diagnose and treat a patient. In full practice, the nurse practitioner has the authority to prescribe, treat patients, as I said earlier, while the collaborative practice requires an agreement with a medical doctor who will oversee prescribing practices. Currently in the United States, there are 21 states that allow the nurse practitioner to practice independently with the supervision of the medical provider. This facilitates the access to health care services, especially in rural areas, by allowing the nurse practitioner to prescribe medications without oversight. It also decreases the cost of health care, smooths out continuity of care, reduces bureaucratic inefficiencies associated with collaborative agreements, and decreases patient confusion about the role of the nurse practitioner. So these are the classes that I took, Doctorate of Nursing Practice. As you can see, these are different ways you can become a Doctor of Nursing Practice. And if you look at my class list, I have classes that are not necessarily nursing: organizational leadership, strategic communication, foundations of healthcare management, health policy, principles of ethical theory, clinical scholarship. It also required 1,000 clinical hours. So this is who I am as in my practice. I'm a school nurse. And we also have standards of practice. And part of the thing that school nurses bring into the daily lives of who we socialize with and who we see as our clients is care coordination, leadership, quality improvement, and community and public health, which kind of, if you look at all my courses that I took, they kind of all fall right in line. School nurses have their own scope of practice, and you can easily see how the courses that I just outlined work. Leadership, care coordination, public health. We are governed by both the school district policies and the Department of Public Health Regulatory Authority, and are licensed to delegate medications to non-medical staff while we're at the school, such as epinephrine and Narcan. The school nurse practice model chart provides an outline of the things that I do on a daily basis. And so if you look in the green column, it talks about important aspects of preventative care, which are health screenings, hearing, vision, body mass index, and scoliosis. That's provided 3 times throughout the student's life as they go through school years. Also, the new school nurse ensures that students who have physicals are up to date, along with immunizations. We collect data, which is used by the Department of Public Health to make decisions on how many pulmonologists will we need later on in life. Is there more incidents of asthma all of a sudden going on? So here's my school. Those 3 buildings I'm responsible for with another nurse. We have over 1,500 students that we see on a daily. I could see between 40 and 90 students at any time. No 2 days are the same. So here's my health office. This little green shelf holds my Band-Aids. I do not dole out Band-Aids. I always tell them, go use the bathroom, go wash your hands, put down your Band-Aid. Because I believe that one of my roles is to teach them how to self-care. And if I don't tell them that they need to start managing their own health, how are they going to manage when they go to college? The other things that we do is we kind of reduce their chronic health issues so that school is a level playing field for them. So maybe a student who has diabetes type 1, maybe they may be taking tests down in nursing so that we can manage their blood sugars, because when you have anxiety, your blood sugar is going to be elevated. So how do we bring them down? We're not just going to give you insulin for anxiety. We're going to give you some water. We're going to have you go for a walk. We're going to give you one page of the exam at a time so that you can really focus on relaxing and not worrying about just all of a sudden giving yourself insulin so that your numbers just drop immediately. So the last thing I'm going to tell you about that we've just started creating in America are school-based health centers. And so, when we think about primary care, we have 2,000 of these serving over 2 million children. And it's a really great way for providing health for students who don't have access to health care, because we have a lot of influx of students coming from other countries currently who don't have their immunizations. And so how do we get them up to date to America's standards? We don't want to have incidences of measles all of a sudden, or incidences of rubella or polio. We want to make sure our kids are immunized. And that's it. Thank you so much.
All right. Now I think I would like to invite the chair, Dr. Rafa Jan, to just come and make her comments, please.
Assalamu alaikum. Thank you, Robin. It's a high time we think different roles in Pakistan, and we need to overhaul our nursing education. Although now we have gone into more degrees program, from bachelor's to master's program. However, mostly once the graduates from master's program, they have good openings only in university, because they get good titles there, from instructor to all the way professor, like myself. But at the clinical side, apart from few private organizations, the various roles of nurses or midwives which needs to introduce. For example, I'm from Aga Khan University. We have infection control nurses, we have case manager nurses, we have even our whole emergency business is run by business nurse manager, and she's the one who's the nurse. And she deals all the time with multidisciplinary teams. So Pakistan, we have to introduce this role at the public sector, because in public sector, mostly understanding is from 12th grade to 16th grade to 18th grade. So it's just the grading system, but roles are not identified. One of the things I was hearing, I'm sorry I couldn't come yesterday, and I'm very grateful APPNA that they have invited and they kept this session. तो आपने हम सब के लिए तालियां बजवाई, प्लीज APPNA के लिए भी अप्लाउड होना चाहिए, इतनी ही तालियां बजनी चाहिए. So I couldn't come, sorry, because in my role, one of my role as a professor, I had to complete my grant, and it was going last day, so I was going crazy. Let me tell you where the preventative start, and you read I've grown up in that system. That's true. When my mother delivered my brother and sister, the lady health visitor used to come at our home. She used to bring cards. She used to tell my mother to come to the health center for vaccinations, for her checkups and everything. We never went to hospital. We went to, and at that time, there was a one very good term, which is now maybe baby friendly for breastfeeding, but in those days, well baby shows. So whichever mother really do a lot of work for the development with the children, they get big gifts because the mother was taking care of the babies. So I think nurses, lady health visitors were the very crucial part. When we were discussing about the preventative care, one of the roles I think, which I think it needs to be discussed, is the role of insurance companies. I myself, when I was as a president of one of the regional voluntary positions, and I wanted to introduce community-based health insurance. I tell you, the whole financial models, from microfinance bank to insurance companies, was the huge struggle for me, because everybody was thinking about money and saving of money, but where was the patient and family? I had to always educate them. But the problem was that some of the customers asked me that I'm paying that money to insurance company, and if I never got sick, what will I get? And one of the things I had hard time with the insurance company was screening. I said, if somebody is putting money to motivate that family, that if they have not utilized insurance money, if we get one checkup annually from that insurance money, which doesn't cost much, and few accepted screening tests. So insurance companies were, no, it's only reimbursement of the tertiary care hospital. With Sehat card, there is a money in Sehat card, in Saaf Sehat card. But if you hear, I mean, our Prime Minister is doing a lot. If you hear most of the talks or speeches, कि ये patient heart surgery के लिए गया या ये patient गया, and we put a lot of money, which is good. But I think somewhere our Prime Minister Imran Khan also have to advocate, because he is celebrity. Imran Khan is celebrated, Dr. Jan is not. So if he says that the prevention also comes from that Sehat Insaf card, then they'll put money into the basic health unit and this thing. Second thing, Robin has showed you very good preventative model. So we have to think about this, that we have to start preventative model. And school health centers are the best example, because that is the time when we catch for adolescents or adulthood all the chronic diseases. That is the place. Third thing I would like to advocate. It is good that we heard for family medicine incentive and this thing. Doctor alone cannot do anything. We have best doctors in Pakistan. They do best surgeries. But the morbidity and mortality come after surgeries, after doctor have seen, because the 24 hours patient care provider are nurses, lady health visitors, nursing assistants, or other allied health. I don't know why we are not putting a lot of attention on those who are with patient 24 hours. It's time. And I invited my two colleagues, Dr. Mushtaba Qadri, may I ask you to please rise, and Dr. Mubin. And I don't know who were there, but for 2-3 years, everybody was telling me कि जी आप तो सिर्फ लाल किले में हैं, आगा खान यूनिवर्सिटी तो सिर्फ रेड फोर्ट है. So I came out and worked with the public sector and National University of Medical Sciences. You heard Professor Imran Majid. There I met with Dr. Qadri and Dr. Mubin. Dr. Qadri and I worked together on complete family medicine and family nurse practitioner model. Implementation is the Pakistan. It's always the good documentation. And with Dr. Mubin, he never conducted a single session without multidisciplinary health center. So for APPNA, may I request, I don't know what will be your theme for next but teams should be multidisciplinary teams and various roles of multidisciplinary. We need to come up with things. Having said roles, I already said that business manager and nurses, a very important thing happened from Aga Khan University. We were the first hospital who went for joint accreditation, which is third-party accreditation. Once they were very impressed, they wanted some CVs, and we sent, of course, it's reverse, it's 2 or 3 doctors and 1 nurse. So we sent 2 doctors and 1 nurse CV. But what happened? They chose a nurse as an international surveyor. Today, our chief nurse, Salma Jaffer, she is one of the international surveyor for joint accreditation. So this is the power of nursing. These are all very powerful nursing expertise. I like to say, if we are working in collaborative models in education and in practice, I think then same thing goes for research models as well, what Robin has said. Without evidences, we cannot function. So we have to do collaborative model. We can't be alone, or we can't work, at least in today's day. So we have to work. Everywhere I'm going, they say 9 million shortage of nurses, 9 million shortage of nursing on, and this 9 million number, so much money came and went into sometimes so much schools which are pathetic. And we are just producing, we want that government numbers. But what kind of quality care our patients need? So I think we need more and more clinical based education. Do you agree? अगर हमारे पास clinical based education नहीं है, and if we are not bringing good patient and family outcomes, then why we are here? Why? So this is what I would like to say. So Robin, you have really touched so many things. I would say if we would like to achieve universal health coverage and sustainable development goals, we have to take multidisciplinary teams and we have to give different roles. So please, आप लोग जब assignments करते हैं और nursing faculty है, please look for different roles. Try to go in Shaukat Khanam, try to go in Shifa International, come to learn what is the Pakistani models. And the best preventative model I have seen and I have grew up is Gilgit-Baltistan model. So look at those best preventative models. Nobody talks, and I've never seen good representation from Gilgit-Baltistan. And those models, very safe, secure, they are run by lady health visitors and midwives. And you look at their maternal, neonatal, and child indicators. These needs to study. Those are Pakistani models. So what's stopping us? What is behind that stopping us, what we have in our country? So let's talk about patient safety. While I'm thankful to APPNA, I would say that with Robin and with APPNA, we would like to continue Zoom model. And Dr. Kadri and Dr. Mubin are here. We have already developed education model, and I think we build on that. Thank you so much.
Thank you, Dr. Rafijan. So next I would like to invite our panelist, Professor Zial.
Thank you so much, Robin. It was a very inspirational which model you have presented. I represent Khyber Medical University as a Pro-Vice Chancellor and Dean of the Public Health. Khyber Medical University, when we started in 2007, and 2009 actually our first institute, that was Institute of Public Health in which I worked. We started in the same time we started the physiotherapy. But soon after that, we found that the nursing education, especially the bachelor program, is only there at Karachi. And in Karachi, when we found that majority of the students are from KP, Khyber Pakhtunkhwa, so then we started this school of nursing, Institute of Nursing, which Madam is here, Madam Shaheen Ghani is here. And Alhamdulillah, it's doing very well. We have a bachelor program and now we started master. And for the first time, we have now 3 PhD nursing at Khyber Medical University. So soon we will be offering PhD in nursing at Khyber Medical University. And at the same time, we work with the private partners, and there are so many nursing institutes coming on at Khyber Pakhtunkhwa in the remote areas such as Bunair and Swat. Only in Malakan division there are about 15, 16 nursing schools in which they are offering the bachelor program. We are shortage of master in nursing program because this is one of the requirements in these schools, that they must have, the principal must have a master in nursing program. After looking to the Robin presentation, yes, we lack the specialization in nursing. So far we are offering the generic nursing program. So at my institute we have public health institute, master in public health, master in health research, and MEC epidemiology. We are offering these courses to the nursing, and believe me, one of the top ranked students, they are mostly from the nursing in those public health programs. So this is the one track we are offering them, master in public health and MEC epidemiology. Second, we are now in discussion with WHO to start a diploma in family medicine for nursing care. We're working very closely with them, and soon, inshallah, in lesser than a year's time, we'll be offering a diploma in family nursing course for our nurses. Another program which we started is a diploma in mental health for the nursing care. An institute, this has been now recognized by the KMU authorities, and it is called Institute of Behavioral Sciences and Mental Health. So we will have mental health programs for that. Coming into the family medicine, the issue is that the basic health unit, there is no nurse position in the basic health unit. What we are planning for this GP program, the family medicine approach, that we will be starting from the BHU, the basic health unit, but there is LHV course, LHV position, lady health visitor, but there is no nursing position. There are nurses at the rural health center and then the teaching, the secondary care, but there is no nursing position at the basic health unit. We develop essential health services package, and I think that the nursing, and I also promised that we should lobby for that an essential health services package at the basic health unit should have a position for the nursing. And then I think I'm also in a task force at the KP level. Madam Shaheen is here at the national level. So together and also with other colleagues, we should work together, because the school health is the responsibility of the basic health unit. And in any of the BHU, we have not seen any activity by this basic health unit, because this is not the responsibility of the doctor, this is the responsibility of the nurse. So we are here with you, and we are learning from this session, and believe me, I'm very impressed from the nursing student at my institute at the Khyber Medical University. You are stars, and without you cannot achieve any universal coverage. Our indicators can be improved. So thank you so much for inviting me.
Thank you so much, Professor. So next I will invite Shaheen Ghani.
Bismillahirrahmanirrahim. Assalamu alaikum, dear colleagues and students. There are a lot of role we learn from in the Robin presentation, and public sector, there is only one thing. When we see the nurse in the white uniform, so we think only tertiary care hospital and no other role in the public sector in Pakistan. तो इंशाल्लाह हमें मायूस नहीं होना चाहिए, और हम मिलके नर्सेज मिलके इसके लिए काम करके ये सारे रोल इंशाल्लाह हम इंटर करेंगे पब्लिक सेक्टर में, एंड यू आर द स्टूडेंट एंड यू वर्क फास्ट फॉर दिस, और हमारे साथ मिल के काम करना है, तो ये रोल अचीव करना है. एंड फॉर द अदर मैनेजमेंट एंड अपना, तो वी शुड वर्क on the system and on the role. So what is the role? We should define the role: physician, nurse practitioner, primary nurse care and primary health care. अब जिधर भी हम देखते हैं तो हर जगह पे नर्सिंग का पार्ट मिसिंग है, और प्राइमरी में तो नर्सिस का नाम ही नहीं है. तो लेट्स वी स्टार्ट द नर्स प्रैक्टिशनर and from the primary health care and family medicine. तो कहीं से हमने स्टार्ट लेना है, और ये जो फैमिली मेडिसिन है तो हम रिक्वेस्ट करते हैं कि इसको नर्सिस के साथ ये पैरेलल चलें. जैसे फिजिशियन डेवलप होता है, इस तरह नर्सिंग केयर को भी डेवलप करना है. तो पब्लिक सेक्टर में तो ये कभी कभी हम जो इतने सारे रोल देखे तो पब्लिक सेक्टर में हम कंफ्यूज हो जाते हैं कि ये कैसे करेंगे. लेकिन जब तक नर्स ये रिस्पॉन्सिबिलिटी अपने शोल्डर पे नहीं लेता तो ये नहीं होगा. तो इंशाल्लाह ये सारे नर्सिंग लीडर हैं एंड वी विल डू इट. थैंक यू.
Thank you, Shaheen. Great comment. That's you guys are all the leaders. Really, we doctors cannot function without you guys. And there are so many levels of nursing care. So that's what our hope is, inshallah. We keep improving the nursing care. I mean, in US, the way we practices, there's a clinic base, but then in the hospitals, are like ICU nurses are so skilled that I think we doctors depend so much on their care to the patient. And they are the ones who are communicating patient's need, how patient is doing. Like many times we just don't have time to come visit each patient any moment. Nurses are so skilled, they'll tell us how the patient is doing, rely on them, and we come back if it's an urgent need. So really there's so many levels, and you guys have so much potential, so keep it up. So our next panelist, I'll invite Rehanna Elahi.
Thank you so much, Dr. Dar, and I'm so thankful for the organizing committee of this conference and APPNA for inviting me and my colleagues here, and particularly planning a session for nurses. That shows there is a great achievement going to happen. My introduction was a little bit has to be complete. I have done Masters in Public Health and MPhil in Educational Leadership. And in my capacity as a director of nursing in a specialist hospital, I'm a cancer specialist nurse. Why I'm telling this to you is not to boost myself, but is if a nurse of my age can do that, the nurse of this age can go beyond that. So I'm a first cancer specialist nurse of Pakistan. In my capacity, as a director of nursing of Shaukat Khana Memorial Cancer Hospital, Lahore and Peshawar, we have a lot of roles developed in our hospital. We have cancer specialist nurses, we have chemotherapy navigator nurses, we have pain management nurses, we have palliative care nurses, we have breast care nurses who are helping, doing in their role, initiating and facilitating the physician in care of patient independently. Very recently, we have introduced a role of tissue viability nurse with our cosmetic surgeon. So how are we developing this is through training, through education. So why I'm telling this, that if a specialty or a specialist hospital which has only 2 hospitals in the country is able to specialize and divide nurses into different roles, how is it not possible that it can't happen in family medicine? It can be very well happen in family medicine. We need to, first of all, we need to strengthen our community health nursing and midwifery role. In our curriculum, for 3 years curriculum, there is a very strong component of community health nursing. But it dies once a nurse completes this degree because nurses' structure in community health is not very strong. Nursing structure in primary health care is not very strong. So what happens is that every nurse wants to go to the tertiary care, which is hospitals. And in the hospital, again, they have to go and work as a subordinate or assistant to doctors. There's no harm in assisting the doctors. There's no harm in subordinating. But then what happens is that this biomedical model gives whole stress of patient care and critical care to the physician. So they are unable to cope with it. So we have to bring nurses forward where they can work independently. So if the government, and we are pushing the government, in my capacity, Dr. APPNA, Shaheen, and there's another, we are in Prime Minister's Health Task Force, we are pushing the government to give a structure in a primary health setting for a nurse so that we can provide more carers, we can provide more education, and we can bring these nurses as a second line of the doctors to help patients and their families. Nurses can, in primary health, nurses can help in assessing the patient, screening the patient, making diagnosis. Like Robbins has mentioned nursing process, and I'm really very happy to say that this process is being taught in many universities in Pakistan. It has been used in many hospitals, and there are different hospitals like Shifa, Aga Khan and Shaukat Khanam. We have actually moved ahead of it, and that is integrated clinical concept med, where the nurse took the patient as holistic, and they take care of everything around it, and then they come up with a care plan which they have to work out throughout their shift or on their patient or during their care period with the patient to solve all those problems. So the nurse in MNCH can help you in antenatal, in postnatal, in conducting deliveries, taking care of neonatals. How the other developing countries have reduced IMR, MMR, respiratory tract infection with the help of nurses. In the morning session, it was mentioned that female doctors don't go to the BHU, RHC because of security reason. I think same is happening with the nurses. Most of the nurses are female. They don't go to BHU, RHC and these areas because they are not protected. And we all know that security is a bigger issue in Pakistan. So if we provide all those facilities to nurses, they can be in different roles. Advanced practice nursing, we are highly advocating that, and we need it. It's a need of time. We need to have nurses with master's degrees doing few credentials, coming with competencies and knowledge, and then working independently so that they, but who will bring that? It's not that we say government should bring this, government should bring that. It's our nursing bodies who should advocate for all these things to come in life, because the time would come. Today we are saying we need so many number of nurses. Are we talking only about hospitals, or we have included community in it? So tomorrow maybe hospitals will be saturated with nurses, and then where the nurses would go? The institution will be saturated with assistant professor and professors and deans and all that. So then where the nurses would go? So we should have to plan from now onward, so that if we are thinking to strengthen nurses' role, where we have to place those nurses in different roles. Thank you very much, and thanks to you.
Great comments and great education you guys did just today. So now I guess we're going to do the question answer. So I have some pre-conference questions that I have, and then some of these questions we'll just kind of try to address as many as we can. So I guess the concept of advanced nurse practitioner, do you think it's a good model for Pakistan, especially in remote areas? Like in US, we do have certainly midwifery is very popular. A lot of patients actually choose to have a midwife rather than even an OB physician, because some people believe in that holistic approach and non-invasive approach, and it works great. They tend to kind of work together with the OBGYNs. If there's any complication arise or something, they are there, so they have connection with them. So what do you guys think about that? So like, do you think the nurse practitioner and the midwifery, like especially for the rural areas, is a good idea?
Yeah, I think it's a good idea, because we should not talk about tertiary care only. We should, and in tertiary care, there are few nurses available in the hospitals, whereas those remote areas where nurses and doctors are short. So when I talk about advanced practice nurse or midwife, I actually do not talk a nurse who has simply done diploma. I talk about that nurse who is prepared to a master's level degree with certain added competencies and courses which help to prepare them to do advanced health assessment, a knowledge of pharmacology, a knowledge of screening, and making patient and family assessment initially, and prescribe medicine, as Robin said, that they prescribe medicine, and where it is required that the situation is critical, the patient can be referred to the physician. So I agree that, yeah, I think it can be worked out.
Yes, yes.
Very much so. In fact, currently I met nurses in Gwadar and Pasni, that coastal side. I met in South Punjab who are running their clinics. I met in Gilgit-Baltistan as well as in Balochistan. Those far-flung area, the families approach to these nurses and lady health visitors. So what we have to do, when Robin was presenting American model, I was at that time doing PhD at the University of Iowa, and doctorate practitioner model was discussed, and it was huge debates were going on that if the nurses are not doctorate prepared, who would supervise in the clinical? And in fact, in nurse practitioner, same thing, grandfather rule. I like that model that we have very, very experienced lady health visitors, very experienced midwives. We just have to give them on-job trainings, and then for those experienced setting up the criteria, we bring the grandfathering approach and bring them into this thing. But that model will be very successful, cost-effective. One thing, it is the fee-for-service model. I would really advocate that from government or other insurance companies, some percentage built in for those kind of preventative and family nurse practitioner model. Thank you.
Yeah, so I think it sounds like it's a good idea to have like a team approach in the rural areas, having a family physician, a midwife, nurse team or something that's there to be more effective, covering the entire small community in a village. So I have some interesting facts here, and then I would like probably you guys to kind of make your comment especially to reduce the risk of asphyxia and intrapartum complications. So according to some of the numbers that have been given, the neonatal mortality rate of Afghanistan, Nepal are lower than in Pakistan. Kyrgyzstan has neonatal mortality rate 10 per 1,000 live births, and they have just 2 neonatal tertiary units in the country. Afghanistan had no obstetricians or pediatricians post-Taliban time. They invested in midwifery and the Kyrgyz Republic in the primary and secondary care, a 4-year program of midwifery on lines of UK program, degree after FSc. Hospitals can introduce the concept of midwifery in units with the labor rooms run by the midwives, and they call doctors when the need arises. So I think so why do you think how can we reduce the risk of any asphyxia and intrapartum complication and to reduce the neonatal mortality? What are the factors in Pakistan you think could be playing a role?
So now you are talking to midwives. The problem is this, let me be very straightforward. The obstetricians are practicing normal vaginal deliveries. And I'm sorry, but this is business model. So I have even president of Midwifery Association and member of International Confederation Midwife, struggling and struggling. So many times I told the head of the obstetrician in Jinnah, which is one of the federal institute, that annually there are more than 16,000 normal delivery taking place. Give 3,000 to 4,000 to midwives. No. Nobody wants to touch that. So the thing is this, Afghanistan, they didn't have any obstetrician, they didn't have one, Afghanistan. Okay. I have many good friends from Afghanistan who are midwives. They are paid through government, and that's the way their outcomes are like that. But do we have will for our public, or we have will for our own incentives? That's the thing.
So I have a question for you. So OB, they don't have this antenatal OB care, so their patients are supposed to do very regular visits throughout the pregnancy to monitor a good, healthy pregnancy, and then outcome will be better. So the midwife, do they have some kind of any antenatal care? Are people very compliant with that? Do you think that would make a difference?
It definitely. I mean, you look at UK model. I mean, it's not that Western country model. I spent a lot of time there. The pregnant women come in the clinic. The postnatal take place mostly at home after 6 hours for normal vaginal delivery. I went and spent time in San Francisco and New Mexico with my midwife friends. I don't know why in Pakistan we are so hesitant that we don't want midwife, and then I get answer, oh, we want midwife like UK or America. Oh, fine, we are bringing them, we are educating them, but if you don't let them practice, where the competency will come? So I think one of the things I'm putting back to APPNA, demarcation of services, demarcation of competencies, demarcation of how the people are going. So if normal antenatal, normal intrapartum, normal postnatal care, and normal essential newborn care, I think midwives' skills and competencies should be there, and they can give us. And that will bring a dent in our indicators, which are not, I mean, look at 70 years history of Pakistan, and look at this thing. So when I'm saying Gilgit-Baltistan, please, if you have time, visit that place, see the model, see how lady health visitors and midwives are running clinic. Please see, and then you can believe what I'm saying. That's a fabulous model.
Yeah, adding to Dr. Rafat's comment, again, what we are actually advocating to the government is to give scope of practice for all the carers, like women health workers, lady health visitors, midwives. Now we have midwives with BSc degree, and we have nurses who have done post-RN in midwifery. So the scope of practice and standard for their practice and credentialing can help them provide safe practice to the mother and children. And similarly for the advanced nursing, the scope of practice has to be set, we give them standard, and we set few credentials, the procedures or the things they can do that can help nurses to provide safer care to the patient, safe and quality care. Yeah.
I also think wrong interpretation of credentialing. Wrong interpretation of credentialing. Yeah, like in Aga Khan University, doctor said, oh, now we are joint accreditation, so midwife cannot deliver. I said, who said this? I have come from the country when joint accreditation is taking place, and midwives are there delivering or providing full scope of care. And the hospitals are joint accreditation, and they are credentialed. But interestingly, I don't know about Shaukat Khanam, but Aga Khan University Credential Committee is Medical Credentialing Committee. And now I'm strongly advocating multidisciplinary credentialing committee. Why some other professionals are credentialed to some other professional? So
we have a standard board which is multidisciplinary, in fact, and me and few senior nurses are part of that.
So great.
We do credentialing, and because we are also JCI certified, both of the hospital at Shaukat Khana, we have nurses. Another role which we have introduced in nursing is the nurses working in quality assurance department. Yes. So the nurses, like in operating room, if a doctor comes and say, I want to do this surgery, the credentialing evaluation is in hands of nurses. If the nurse says you are not credentialed for this surgery, I won't allow you to do it, he won't be able to do it. So that's the empowerment of nursing through different roles and knowledge.
So we have now first nurse lactation approved at the Aga Khan University. बच्चों ये different credential हैं apart from nursing license. Nursing license is not enough because our regulatory mechanism needs to go beyond licensure. So they are licensure, but then there is another kind of credential. So we have now given credential to nurse lactation, but to give like stoma nurse, dressing nurse, all the other nurse navigators and this thing, two things we need. One is our legal boundaries, which is hampering us, and we have given Nursing Council Act, but like in the morning we were hearing that government machineries are so good, mashallah, how to hampering or creating hindrance. So as soon as those acts will be approved, the nurse practitioner, clinical nurse practice roles will be legalized. And once they will be legalized, we have put all those things about the scope of practice, and then the regulation will be promulgated from this kind of law. So I think, and also I'm happy that Vice Chancellor of University is here. I'm also advocating for bachelor's nursing or those nursing directors go and sit all the meetings, including the syndicate. So they won't be removed, and credential committee should be for every multidisciplinary. So we have examples here, but it's good. We are struggling. Nothing is keeping for us in the silver plate, but that's good, and we are keep struggling for that.
Start from the role of the primary, the family health care and physicians. We also need first start with the nurse practitioner in the primary health care.
Thank you. So I guess, again, I have some facts here. They say in Punjab, around 50,000 appear for the medical entry test. Only 3,500 get admission. Remaining females certainly are potential candidates. How can we, because there is so much need for per patient population here, there's shortage of doctors, there's shortage of nursing staff. How can we increase this availability that people who are interested in going to that profession, but they just cannot enter because there's no room for classroom? I don't know, I guess how many schools we have, and is there potential room for growth?
Yeah, I think as I mentioned that in the recent past, there are many private schools offering this special program. So at the moment, I don't think so that there is any shortage of, there are more in private sector,
Okay.
but it's happened in the last 6 months. Many situations. Now the quality is a problem. How they will keep their quality, but the number is there, I think. So.
Yes.
I agree, number is there, but the problem is with the clinical practices side by side, because nursing is not theoretical, so that's we have to really keep our eye on.
I have a question from the students here probably. So PNC has started diploma in nursing with severe shortage of nurses. Will BSN be able to cover this deficiency?
Okay, this is one of the myths, and let me explain in Urdu. डिप्लोमा बंद होने से नर्सेस की कमी नहीं होगी, वही डिप्लोमा प्रोग्राम 4 साल में, अब 4 साल चलता है ना, 3 साल आप लोग डिप्लोमा करते हैं नर्सिंग में और 1 साल डिप्लोमा करते हैं मिडविफरी में, ये बनाता है 4 साल, राइट? यही 4 साल हो जाएंगे उसके लिए, बैचलर्स के लिए. लेकिन अगर आप बैचलर्स नहीं एंटर होते हैं डायरेक्टली, तो कितना लंबा सफर हमें करना पड़ा था कि हम 4 साल नर्सिंग पढ़ते हैं, फिर 2 साल प्रैक्टिस करते हैं, उसके बाद जाके हम 2 साल में हम बैचलर्स करते हैं, राइट? तो थोड़ा सा इसको सोचिएगा कि आप बैचलर जब करते हैं डायरेक्टली, तो उसके बाद आप क्लिनिकल स्पेशलिटी कर सकते हैं मास्टर्स के लिए. दूसरी चीज, लुक एट द हायर एजुकेशन कमीशन. हायर एजुकेशन कमीशन ने वही मॉडल दिया है जो रॉबिन ने एजुकेशन पाथवे बताया है. अवर हायर एजुकेशन गेव सेम पाथवे. तो डिप्लोमा की जगह पे अगर हम अच्छे से उन डिप्लोमा को एसोसिएट डिग्री में चेंज कर दें, तो वो भी यूनिवर्सिटी में आ जाएंगे. तो काइंडली आप डॉक्टर यास्मीन रशीद के साथ लेके थोड़ा सा बनाए तो एक एजुकेशनल पाथवे बन जाएगा कि अगर डिप्लोमा प्रोग्राम स्टार्ट नहीं करना तो कोई बात नहीं, गिव इट न्यू लुक, उनको एसोसिएट डिग्री में चेंज करें, यूनिवर्सिटी के अंदर में लाएं और फिर आगे का कैरियर पाथ जो है वो बैचलर्स और मास्टर्स हमें ज़्यादातर स्पेशलिटी में चाहिए। इवन जो हमारी डिप्लोमा नर्सेज हैं उनके लिए पोस्ट RN हो सके तो स्पेशलिटी में करें, जैसे शौकत खानम जो है वो ऑन्कोलॉजी स्पेशलिटी कर रहा है। तो कोशिश हमें ये करनी चाहिए कि ज़्यादा से ज़्यादा हम यूनिवर्सिटी में लाएं। रीज़न ये नहीं है कि हम सबको ग्रेजुएट, रीज़न ये है हमने खुद रिसर्चेस की हमारे स्टूडेंट ने कि यूनिवर्सिटी में एक तो बहुत ज़्यादा करप्शंस नहीं है और यूनिवर्सिटी स्टैंडर्ड्स मेंटेन करती हैं एजुकेशन का। दैट्स इट।
इससे मैं भी अगेन ऐड करना चाहूँगी। डॉक्टर रफत हैव सेड इट वेरी वेल एंड एक्सप्लेन इट वेरी वेल। ये मिथ आपके ज़हनों में डाली जा रही है, उस तरफ से थोड़ी सी एंजाइटीज़ और अनसर्टेनिटीज़ आ रही हैं कि शॉर्ट हो जाएंगे, लेकिन आप ये सोचें कि 4 साल की डिग्री के बाद 2023 में जो आज स्टूडेंट इंडक्ट हो रहे हैं वो 4 साल के बाद जब इंटर्नशिप में आएंगे तो पूरे का पूरा बैच पूरा साल उस हॉस्पिटल को एज एन इंटर्न सर्व करेगा। देयर विल बी अ वर्क फोर्स इन द हॉस्पिटल एंड देन दिस विल कंटिन्यू ओवर years and years and years. I want to sensitize you, the young population. I want to sensitize the teachers sitting in this hall, and I want to sensitize the nurses sitting in this hall. One of the graduates who has done FSc and get admission in physiotherapy is a doctor of physiotherapy. A person who is FSc and get admission in pharmacy is a doctor of pharmacy. 80% of the nurses coming to nursing with FSc and they are diplomate only. Do you want to stay nurses with diploma? Do you want to increase your number of your years to reach to the degrees like us? For God's sake, do not think about all these things. If the government have phased out diploma, please let it be. Year 1 and year 2 will be a difficult year, struggling year, but year 3 and year 4, inshallah lazim, the need assessment which Health Task Force have done, according to that, you will be able to manage all these things. First step is always difficult. Change is always hectic, but we have to change it. So please let it be.
So I guess we are kind of running. You want to make a quick comment?
एक तो ये जैसे कि आप BSc कर लेते हो तो आपके लिए कितने ज़्यादा एजुकेशन के वेन्यू खुल जाते हैं। आप कोई जो है ना मास्टर करता है, कोई किसी मास्टर में स्पेशलिटी करता है, क्लिनिकल मास्टर करता है, फिर आगे PhD। जब डिप्लोमा में होते हैं तो आपको 2 साल पोस्ट RN करना पड़ेगा, उसके बाद भी HSC उसको रिकॉग्नाइज नहीं करते किसी फर्दर एजुकेशन के लिए, तो इसलिए अब ये बहुत ज़रूरी है।
Okay, I have one last very burning question because we need to kind of end the session. We're running out of time. And this is actually from the audience. Why do the parents think it's stigma to make their daughters a nurse? Which I think I've been out of the country for so many years now, but I think that is one of the issues that I felt like a lot of girls didn't want to go to the nursing because really it was kind of thought of as not, but I think it's a very respected profession and we need to elevate that and change the mentality of the community that this is just as important in healthcare like physician or lab tech or whatever, but I'll let you make a quick comment.
I think it's society. It's the how society see nurses. और प्लीज आप लोग जरा हमारे मीडिया को देखें, वो हर ड्रामा आजकल आ रहा है उसमें एक पेशेंट एडमिट होता है तो वो खाम की जो नर्सेस दिखाते हैं उसका तो यूनिफॉर्म देख के मेरा भी दिमाग घूम जाता है। तो मीडिया भी ऐसे ही प्रोजेक्ट कर रहा है, मैं ये उर्दू में कहूँगी, आप रॉबिन को देखें, जो बाहर की नर्सेज हैं वो मिक्स मैरिजेस जो होती हैं डॉक्टर्स के साथ, यहाँ पे तो अगर किसी डॉक्टर ने नर्स से शादी कर ली तो पहले जाके पेपर्स भरवाए जाते हैं कि इनकी शादी तुड़वाई जाए, और ये ऐसा होता है। या फिर जिन्होंने नर्सेज से शादी की वो मुल्क ही छोड़ के चले गए। इतना स्टिग्मा रखा हुआ है यहाँ पे, तो ऐसी बात नहीं है कि ये नहीं है। हम भी बहुत, मतलब माय फैमिली इज बिजनेस फैमिली। माय फादर वांटेड कि मैं पाकिस्तान के फॉरेन एम्बेसी में काम करूं, इसीलिए उन्होंने मुझे इकोनॉमिक्स, इंटरनेशनल रिलेशन, ही पुट मी इन दोज कोर्सेज। आई हेटेड दैट, गोइंग टू यूनिवर्सिटी जिधर एजुकेशन ही नहीं होती थी। एंड देन सडनली समबडी टुक मी फॉर नर्सिंग। तो माय फादर सेड, ये ही डिडंट से कि इमेज क्या होगा, ही सेड मुझे नहीं लगता है वहाँ पे कोई एजुकेशन होगी, तो मैं घर पे तो बैठ के मैं अखबार और सब रीड करवाता हूँ, वहाँ पे रीड करोगी। सो स्टिग्मा जो है वो पूरी सोसाइटी बना रही है, और फिर हम लोग इतने सबऑर्डिनेट बन गए हैं। लाइक रॉबिन हैज प्रेजेंटेड, देयर आर इंडिपेंडेंट रोल, देयर आर कोलैबोरेटिव रोल। हम इतने सबऑर्डिनेट बना दिए हैं कि कुछ कहीं तो इंडिपेंडेंट ऑर्गेनाइजेशन के एक्ट में नर्सेस को सब ऑर्डिनेट लिखा गया है, लिख दिया गया है। तो वो सब ऑर्डिनेट की तरह जब आप डील करते हैं तो एक कॉलोनियल सिस्टम आ जाता है, एंड देन कॉलोनियल सिस्टम में स्टिग्मा, स्टीरियोटाइप्स बने हुए। हमारे पास बस नर्स का एक स्टीरियोटाइप बना हुआ है। तो आई थिंक कि आज आप लोगों ने हमें बहुत रिस्पेक्ट दी। आई विश ये रिस्पेक्ट आज मीडिया पे भी चली जाए। और हम किस तरह से डॉक्टर्स और नर्सेज बैठ के कर रहे हैं। मुझे 1 मिनट सिर्फ दीजिएगा, मैंने डॉक्टर कादरी को बुलाया जिन्होंने हमारे साथ काम किया। डॉक्टर कादरी, 1 मिनट के लिए आप बता दें कि हम नर्सेज और आपने बाहर भी और पाकिस्तान में भी कितना कोलैबोरेटिव काम किया, और आई विश ये मीडिया पे आए।
अस्सलाम वालेकुम, मेरा नाम मुस्तफा कादरी है। आई एम नेफ्रोलॉजिस्ट बाय प्रोफेशन, but I've also played a little bit of cricket, a little bit of education and research in the country. Or one of my primary goals has always been to work collaboratively, basically because of the nature of what I do for my dialysis patients. For the last 30 years, we've been working very collaboratively as interdisciplinary teams. And usi se ye cheez khayal aayi, or through education at Shifa College of Medicine, baad mein National University of Medical Sciences, King Saud bin Abdulaziz University of Health Sciences, and working with colleagues such as Professor Mubin Iqbal, who without a doubt is the leading clinician educationist of this country. So when you put together that experience, working collaboratively with nursing comes naturally. क्योंकि हम जब health care deliver करते हैं, we are a team. Individually, a physician is nobody. The team is your team of physicians, your nurses, the social workers, the nutritionists, the physical therapists. That's what the team is about. So when you're talking about team-based learning and team-based care delivery, ये सारा एक ही paradigm है. So as one of the initiatives, I think I'd just like to share with the group here, that Professor Mubin Iqbal had already started a multidisciplinary training program for professionals in various aspects of innovation and education. And we are trying to put together something further on it, and inshallah we'll be trying to seed an institute for innovation in education, research, and quality and patient safety, and it will be an inter-health professional institute, where all you physician leaders, nursing leaders, pharmacy leaders, and other social workers can come together, collaboratively learn that mutual respect so that we can grow together as a society. So that's just my 2-bit for this conference. I thank APPNA for inviting us, and obviously Rifat has put in a lot of good words for me, but actions speak louder than words. So what we need to do is try and put all this collaborative energy together and move a step forward. We have years and years and years of conferences where we go out and simply forget what happened that day. Let it not happen this time. Thank you very much.
So yeah, I think in any profession, no matter whether it's a doctor, nurse, or janitor, anything, I think number one thing is that how we communicate with people, that's what's the most impression that you leave. So I think the nursing is probably the first contact with the patient. The doctor actually usually comes and sees him after that. So I think it's not about just taking vitals and doing the job. It's being able to connect with the person as a person, because patient, you have to look at it as a person, not just numbers and vitals. So I think that's where we all need to learn in our profession, to be kind and humble and being able to communicate with a patient effectively, leaving an impression so they want to come back to us. But thank you very much for all the panelists and speaker, and thank you very much, Robin, for coming all the way and sharing your thoughts with us. So I really appreciate that. Thank you, everybody, all the organizers, and this ends our session. Thank you.
Assalamu alaikum. Thank you for this powerful session that we just had. I think that was really, I would say that was my favorite session about nursing. And I wish that that what we talked about here, that will happen, that the nurses and doctors should collaboratively work. It's the part of the same team which will deliver the primary care and family medicine and the whole of the healthcare. So now, with that, I think we conclude the working sessions, but there is one breakout session left, which will, of course, happen in the main building, the RMU campus. But here, I would like to invite Vice Chancellor Dr. Umar to come for concluding remarks, and also I will request Mr. Fazal Makin from HEC to come a little later for the shields to be given out from the HEC. So first, Dr. Umar, please come and give your concluding remarks and vote of thanks.
Namduhu nusalli ala rasulihil kareem, bismillah ar-Rahman ar-Rahim. To worthy participants, ladies and gentlemen, it is indeed an honor and pleasure to conclude this session, and as well as pleasure is all mine, and Rawalpindi Medical University really feel honored to thank everybody here. I think I can't discriminate that who did the best. I think that everything was the best, and the last session basically put every record of the previous sessions slightly lower as compared to this. So my congratulations to my nurses colleagues. Once again, I'm formally thankful to APPNA. मुझे अब ये अपना वो जो आज हुआ है कि इसको ये नहीं कहना है अपना कहना है कि ये अपना भी जो है ये पाकिस्तान के ये अपने डॉक्टर हैं, ये वो अपने वाले नहीं है, नॉर्थ अमेरिका में. So I'm also really grateful to the Higher Education Commission who give us this opportunity to being the host, and not only host but the good learner also. I'm also grateful to the APPNA Merit and my very dear friend Dr. Shahid and Dr. Zahid, who are basically key and the key player in all this program, and not only the key player but the role model for whole of the Rawalpindi alumni, as well as they are now becoming the leader of Rawalpindi Medical University and ambassador all over the world. So I thank you once again. I'm also thankful to our Department of Medical Education, our organizing committee here, and rest of the members who really work hard to hold this event. I'm also grateful to the organizing team of the other supportive staff who work day and night to make this a great success. But believe you me, this would not have been a success unless all of the stakeholders did it religiously. तो अगर मैं ये कहूँ कि मैं तो अकेला ही चला था सूए मंजिल, लोग मिलते गए और कारवां बनता गया, तो ये गलत नहीं होगा. Thank you very much once again.
Mr. Fazal Makin, please come for shields along with the RMU Vice Chancellor. As you know, this was a collaborative effort by the HEC Higher Education Commission as well as Rawalpindi Medical University to host, although APPNA was also one of the collaborators in this conference, but these are the two hosts, and I would like them to hand over the shields. So first I will request APPNA President Dr. Nahid Usmani to come and receive her shield. Next, I'll request the main organizer, my co-chair, the merit co-chair, Dr. Danish Bhatti, to come and receive his shield. He was the main, all the work behind, especially the CME agenda, setting up all these conferences, doing a lot of work behind the scene. Well deserved. Good. Next, I will invite, representing the National Family Medicine Committee, is Dr. Nasir Shah from University of Health Sciences. Nasir Shah is very one of the pioneers and very involved and passionate about family medicine in Pakistan. Next, I will invite another very passionate and really great leader in family practice who has set up the family practice department in Khyber Medical University, Dr. Jalil Khan. Next, I'll invite our special guest from US, Robin Rudolph. Next, I'll invite the organizer on behalf of Rawalpindi Medical University, Dr. Shazia Zaid. She has been involved all along this, and she has really helped us in every way. Next is one of the other organizers and representing Canada, Dr. Zahid Rafiq. Zahid Rafiq has taken the main lead for setting up the family medicine department in RMU. So, from the HEC, like I said, Higher Education Commission has been the partner and main organizer of this conference. So on behalf of the organizing team although Dr. Zainul Abidin is here, but to receive on the organizing team behalf, I would request Mr. Fazal Mekin to receive that from Dr. Umar. So Thank you, Higher Education Commission, and thank you, Dr. Zainul Abidin. They have worked really hard with the whole team. So next, I would request you to give shield for Vice Chancellor Dr. Umar. Without his, support. So I think one more I will take, and then I have 3 more for. We have 3 more for our guests, APPNA delegates from US. First, I'll call Noreen Rafiq. Dr. Noreen Rafiq is from Omaha, Nebraska, and she has started the curriculum already with us for the Pakistan, and she heads the department of, she's associate professor in the Department of Family Medicine in the Nebraska University, Omaha. Next, I will invite Dr. Bushra Dar, who is the family practice veteran in Minnesota, Minneapolis, and she is also the president of Minnesota chapter, APPNA Minnesota chapter, Dr. Bushra Dar. Finally, I will also invite another delegate important delegate from US, Dr. Fiza Gilani. She heads the HIV, and she wears many hats. She is very pivotal part of the Brown University HIV program, as well as the multidisciplinary and medical health record, and so many hats she wears there, and has run HIV program for many years, and is very involved in the HIV prevention program in Pakistan and raising awareness. Dr. Fiza Gilani, all the way from Boston, Rhode Island, USA. I just want to mention that Dr. Jahangir Sarwar is not here, but he was very involved along with Shazia Zaid and Professor Rayasgar and Dr. Zainul Abidin. These were the core organizers of this conference. So we thank all of them. Thank you.